Hi, thanks for joining us on Friday of 2022 MRI Safety Week. I'm Alan Heffron, MRI Safety Trainer, MRI Technologist. And we're joined today by Toby Gilk, MRI Safety Man Extraordinaire, a man who does not need and will not get an introduction unless he wants to do it himself. But we're going to discuss the anniversary of the American College of Radiology's white paper on MRI safety, which has since evolved into the MRI guidance document. Toby, can you talk about how the document came into existence and how it evolved into what it is today?
Sure. So it's fitting this is MRI Safety Week. The reason for MRI Safety Week being this week is the anniversary of the tragic accident where the young boy Michael Colombini died when a ferrous oxygen tank got brought into the scanner room where he was positioned for a study. The tank goes flying, strikes the boy, and the boy dies of the injuries. That event, which occurred in the summer of 2001, really sort of galvanized the attention of the radiology community and recognized that in the US, at least, we didn't really have anything in terms of formal guidance for MRI safety. So that, as I say, that accident kind of galvanized the attention of the community, in particular, the ACR, the American College of Radiology. And so the ACR formed what they called originally sort of their blue ribbon panel on MRI safety. Over time, that sort of morphed into an MRI safety committee, sort of a standing committee within the ACR. But originally, it was this blue ribbon panel, and they wrote what I think was originally anticipated to be a one-off kind of thing, guidance on MRI safe practices. The first version of this document came out almost exactly a year after the Colombini accident. Colombini accident was late July. I think the actual official publication date for the original white paper on MR safety was June of 2022. And it was, as I say, the first time that there was really sort of a vendor neutral, societal provided best practice guidance document for MRI safety. And I think it had a really profound effect, at least in the US, in terms of giving people sort of a frame of reference for what constituted MRI safety best practices. So that original document was published in the summer of 2002. It was updated and revised, and the name was changed from White Paper on MR Safety to Guidance Document for Safe MR Practices in 2004. And then it was updated and expanded again in 2007, 2013, 2019, and 2020. And the 2020 version, the ACR changed the name again and the format so that it's self-published. It's internal to ACR, and now it's called the Manual on MR Safety. And as of this year's MRI Safety Week, the most current version is the 2020 Manual on MR Safety.
Toby, do you have an idea how often the reviews and updates will be published?
I don't know. That's a really good question. I mean, from 2002 to 2004 was 2 years. From 2004 to 2007 was 3 years. But then they went 6 years to the 2013 edition, and then went essentially 7 years to the 2020 edition. So although there was a 2019 updates and revisions document that was essentially sort of the coming attractions movie trailer of what the 2020 document would be. So there hasn't historically been we're going to update this every 2 years or every 4 years or whatever that interval might be. It's just been updated, I presume, when they make the determination that there's enough new information or enough of a pressing need for, reinforcement. So I don't know. I had been involved with the ACR's MRI Safety Committee before and contributed to what was the 2007 document and the 2019-2020 documents, but I'm not directly involved with the committee anymore, so I don't have any insight into their discussions about if or when there'll be an update.
Thank you. One of the things that I'm asked frequently, as you're aware, I travel and train folks on our Metrasens products. One of the questions that we see from both technologists and managers is regarding the staffing models that the ACR has recommended and the changes that are resulting from that. Can you talk about what those changes are and some of their potential impacts?
Sure. So first off, credit where credit is due. The staffing model that appears in the 2020 document was not generated by the ACR, even the folks on the ACR's MRI Safety Committee. That staffing model originally came from the VA healthcare network. So the VA in the United States has it's called an MRI Safety Directive, and essentially it's sort of minimum performance criteria across all VA facilities with respect to MRI safety. And one of the elements is what they call +1 staffing. If you have a control room with one magnet, you're going to have a tech, minimally one tech running that magnet. You should have +1. You should have an additional body, in that controlled access space within zone 3 or zone 4. If you have two magnets that share a common zone 3 control space, then you should have those two techs driving those two magnets +1. You should have a third MR safety trained individual working within the controlled access part of that MR suite. So that's the model. It has been, unfortunately, kind of misrepresented in a few ways or misunderstood. One of them is the idea that it says you have to have two people per magnet. Now, if you only have one magnet, one tech running the scanner plus, somebody to back them up equals two people for that first magnet. But that doesn't mean that, if you have 2, 3, or 12 magnets, some of which share common resources, common control areas, common zone 3s, you don't have to have, 2 per each magnet. The other thing that I think often is misunderstood is that second person doesn't have to be an MR tech. It can be a tech aide. It just needs to be somebody who is MR safety trained appropriate to that environment. So it doesn't have to be 2 per magnet, although it is for the first magnet. And it doesn't have to be an MR tech. So that's sort of the structure. The VA originally developed it, and then the ACR MRI Safety Committee adopted it and reproduced it. Now, one of the big questions has been for those sites that are ACR MRI accredited, what are the implications of the ACR MR Safety Manual? What of that do we have to follow as an ACR MR accredited site? And here's where things get really weird and fuzzy and ambiguous. So if you look at the site requirements for MR accreditation under ACR criteria, the site requirements make no mention of the ACR manual on MR safety. It is mentioned in one, and to the best of my knowledge, only one location in the ACR's MR accreditation criteria, and that's under the personnel requirements for the MR supervising physician, modality supervising physician, or MR medical director. The physician who essentially signs off as an MD or DO on the ACR MR application there are specific obligations identified for that person under the ACR accreditation regime. And that person is obliged to make sure that the site is following safety best practices. In the case of MR accreditation, because ACR offers nukes and CT accreditation as well, but under MR accreditation, that means that this MR medical director is responsible for making sure that the site adheres to and follows the 2020 manual. But there are a few things that structurally, this is just completely backwards. In most hospitals, the medical director works for a radiology group that's essentially contracted to the hospital. They're not hospital employees. They have no sort of supervisory capacity over the radiology administrators or the techs. They're sort of on a separate parallel pathway. So they don't really have the authority to dictate operational policy and those sorts of things. They can't hire and fire the techs. And yet they're supposed to be individually responsible for making sure that the policies are implemented at the point of care. So that's a structural problem that I don't think the ACR really wants to clarify, because number two, when there was a big fuss about this +1 staffing model and the notion that it was a minimum expectation or minimum requirement of ACR MR accreditation, if you go on the ACR's webpage that lists the requirements, the personnel requirements for the modality supervising physician, they mention specifically the +1 staffing model. It wasn't there when they first released the 2020 manual, but I guess they got enough sort of, what are we supposed to do about this kind of questions. They actually went back into the personnel requirements and gave the +1 staffing model as an example. These are not the exact words, and I'm paraphrasing here, but essentially it says something to the effect of, yeah, guys, you're supposed to follow the 2020 manual. We get lots of questions about the +1 staffing model. We're not going to check. We, the ACR, are not going to check that you're actually doing what we say in the MR safety manual. However, we, the ACR, reserve the right to throw you under the bus if something bad happens and we can attribute it to the fact that you didn't have the staffing that we recommend. Man, you are just going to get hung out to dry so fast. Now, obviously, I'm making a little bit more dramatic than it says in the ACR documents, but that's the way that I read it and interpret it.
Yeah, there's a lot of discussion that online and in person that I see concerning that. And changing those staffing models is painful for a lot of institutions. But it certainly is in the interest of safety, because I think we've all seen those circumstances in which when you don't have enough staff, or you don't have enough properly trained, level 1, level 2 folks that are capable of jumping in. Can you kind of point out the differences between level 1 and level 2 trained personnel according to the manual?
Sure. The manual is strangely lacking details when we get into this. So the basic concept, level 1 is lower than level 2. Level 1 MR safety training is you are trained to a level where I don't need to worry about you doing something particularly stupid yourself, right? You can independently sort of operate safely once you're within controlled access parts of the MRI suite. If you're in zone 3 or zone 4, I shouldn't have to worry about you, forgetting to take the cell phone out of your pocket or those sorts of things. That there should be sort of a basic understanding of safety knowledge. At level 1, I don't expect, and in fact, institutionally, I really shouldn't allow a level 1 trained person to have responsibility over the MR safety of another human being. Enough to really kind of not start forest fires yourselves, but you don't know enough to really be able to recognize what might be problematic behavior or, risk factors in other people in other situations. That's level 2 training. So level 2 training is whatever it took to get you to level 1 plus additional to help you understand enough about the risks in the MR environment that you can identify them not only in yourself, but in other people and equipment and material that's brought to the MR environment. Now, in terms of what constitutes appropriate or acceptable training to make somebody level 1 or from level 1 to, advance them to level 2 training, the ACR is really, here's where they go, quiet in terms of the level of detail. They don't say. Everything is supposed to be up to the individual supervising physician, the MRMD, and that MRI supervising physician is supposed to define, okay, here are the minimum things you need to know to work, as a level 1 person, as a level 2 person. I also think that one of the failings is a little strong, but one of the oversights of the structure that the ACR put forward is the level 2 personnel. So people who really have the capability to be responsible for other people inside the MR environment. Technically, every radiologist who reads an MR study is legally responsible for the safe execution of the exam that they're reading. So they legally are responsible for MR safety for every patient, every study they read. So radiologists are therefore in the same bucket, the same, level 2 bucket that our techs are. But tech MR safety training could and should include, how to reduce the SAR for a particular pulse sequence, or how to recognize, what the slew rate is and whether or not that's a problem for this particular, implanted neurostimulator, those sorts of things. That level of granular technical knowledge, I would not expect radiologists to really understand, and I wouldn't see any great benefit in training them in this information because they're not going to put it into practice. So,
right.
So if techs and rads are both level 2, and yet we're going to clearly define different training needs and expectations, how can we are we dumbing down the technical training? We're eliminating the technical training for the MR techs so that we get them on par with the rads? Or are we forcing the rads to learn stuff in order to, emulate the training that the techs are getting so that everybody's in the same bucket? I think we really need to have tech and non-tech level 2 training. And the non-techs should include all of the radiologists. Anybody who ever reads MR or ever takes call for MR, all of those radiologists need to be trained to a non-tech level 2. I also think that, the risks of patient care in the MR environment can get pretty sticky. I want the anesthesiologist, the, electrophysiologist, physician or tech who's in there observing a pacemaker patient. I want them to understand the, flow potential and the fact that the magnet is going to produce an elevated ST segment in those patients. I want them to understand why. I want them to understand how to, rectify that so that they don't freak out and think that, the patient's, having heart failure just because we put them in the magnet and their EKG waveform is distorted. So I think a lot of folks who have direct patient care responsibilities, particularly when we're incapacitating the patient, increasing the acuity of the patient, those sorts of things, those caregivers, I believe, really, we should be pushing them towards a non-tech level 2 MR safety training so that they have a fuller appreciation of the environment they're working in and how that affects their ability to care for the patients.
So I've heard you mention this concept before of having multiple level 2 trainings available depending on the person's role. I think that makes a great deal of sense.
Yeah, and that's not to say.
Excuse me.
I think we can say, right now we have small and large, right? Level 1 and level 2, based on the ACR's definition, and I'm suggesting we should at least have small, medium, large, and even then, there are going to be sites where small, medium, large may not be enough differentiation, enough specificity in terms of the level of training based on different levels of competency and care and attention that's needed inside the MR environment. So I can envision a site where they might need, 4 or 5 or 6, sort of different levels. So there should be nothing that should stop an MR medical director from saying, yeah, we're going to train you to a level 1 or to a non-tech level 2, and here's the base curriculum to achieve whichever level we're designating. But because of your additional responsibilities in this environment, I think it's really important that you understand code response procedures if that's not bundled in, the base curriculum. You really need to understand, elevated ST segments and flow potential or whatever that might be. And so we can have small, medium, large, but I think the notion that there might be particular informational needs that are sort of modules that get plugged into, added on to the various levels. I think we need to be more intentional about how we define MR safety training needs based on who's doing what and what risks they have unto themselves, unto other staff, and unto patients, and then build training and competency requirements sort of around what people actually need to do.
Yeah, that makes a great deal of sense. Changing gears a little bit, one of the concepts that was introduced in the 2020 version of the safety manual was the concept of a timeout at the doorway. Can you discuss that, what that should look like, and how that should be carried out in practical terms?
So it's, again, the MR Safety Committee, not afraid to steal good ideas from other areas. We've had timeouts, pre-surgical timeouts for decades. And it has been really effective in terms of, for example, reducing, wrong patient or wrong side, wrong site, types of surgeries. Hey, do we have the right patient? Are we doing the right study? Are we doing the right procedure? Is it in the right location? Is everybody clear? Everybody on the same page? To just reduce the potential for confusion and error associated with the care of an individual patient. Now, in surgical environments, the risks tend to run a little higher than they do in MR, but we have lots of errors, some of which result in damage to MR equipment or harm to patients. We have lots of errors that really have communication breakdowns as one of their central pieces. So the idea behind the full stop timeout type of process is, let's just make sure that we have an intentional step where we make sure, from a communication and information perspective, everybody involved in the patient's care is on the same page. So as we're getting ready to take a patient in, particularly patients who can't communicate either because of acuity or sedation or language barrier, those sorts of things. There's sort of this notion that in an ideal world, patients would actively participate in their safety in the MR environment, which I think is aspirational is sort of the most, charitable way to look at it. It's foolish. The laws of physics, as people understand them, change when you walk inside that room. We really can't and shouldn't depend on patients to squeeze the ball or to tell us that, they feel something funny. I mean, yes, we hope that they do these things, but those things alone aren't effective tools to stopping injuries and accidents from occurring. Those are usually the horses out of the barn type of moments. And yes, we can probably stop further harm or damage or whatnot, but we really want to be able to identify the problems before that moment. So the whole timeout process is essentially everybody, all of the trained caregivers who have a role in the care of this patient. We're going to make sure that we've all coordinated what the screening for both the patient and material and objects that are going in with the patient. The full stop process is really described in the context of inpatients or, sedated patients. But I think that general process can be sort of scaled down and applied to any patient situation. And the ultimate objective is, does everybody understand what's being done? Does everybody agree on, the scope and nature of what we're going to be doing with this patient? Have we verified the safety of the patient and equipment and material that we're taking in? Good. Everybody on the same page? Let's proceed. It doesn't have to be, a 10-minute checklist procedure. It can be, 20 seconds. In most cases, and just sort of a quick pause. Have we double checked? Is everything clear? There's nothing hiding underneath the blanket of this patient. We did double check to make sure there are no O2 cylinders between their legs on the transport gurney, that sort of thing.
Yeah, I think that's going to go a long way towards improving patient care overall.
Right.
In MRI. One of the things that I've found from speaking to technologists across the country and is when there is an incident, when something does occur with or without patient or staff injury, what are the avenues and what are the requirements and what are the recommendations for reporting that? Because they seem it seems to vary across the spectrum who reports it and if it's reported at all. Can you discuss what the requirements are and what the recommendations are? Sure.
So with the caveat first that you may live in a state that has mandatory state reporting requirements. State of Pennsylvania, I know, has this, and they publish their results periodically. So some states have state-specific reporting requirements, but I'm going to speak more to the national, the federal requirements throughout the United States. You have to report something if you kill somebody. That's the only unambiguous reporting requirement. There are other things where they intend for you to report, but things get a little fuzzy. So the FDA actually has 3 reporting triggers, right? So the first one is you kill somebody. An accident involving an FDA-regulated drug or device, winds up resulting in the death of somebody. Both the hospital or healthcare provider and the device or drug manufacturer both independently have a reporting obligation to the FDA if somebody dies. Short of death, things begin to get a little murky. So the next trigger after death is serious injury. And I believe the FDA defines serious injury as something that requires hospital admission. So if you get hit with something and it breaks your arm or your leg and they put you in a cast and don't actually admit you to the hospital, the fact that we've broken your leg or your arm or whatever is not technically a mandatory reportable event because it doesn't rise to the level of serious injury because we haven't admitted you to the hospital. If we give you a laceration that requires 50 stitches, probably doing that in the ED and sending you home. So again, not mandatorily reportable. If there is a serious injury accident, the healthcare provider is supposed to report it to the equipment manufacturer. And then the equipment manufacturer is supposed to investigate the incident and report it up to the FDA. So if you did injure somebody, and in an MR environment, and the patient did result in, the injuries resulted in their being admitted to the hospital, if the hospital doesn't tell the MR manufacturer, GE, Philips, Siemens, Canon, whomever, if they don't tell those guys, the hospital's under no direct obligation to report that straight to the FDA, and then the manufacturers can essentially be, the monkeys who see no evil, hear no evil, speak no evil, and so they can only report the things that are reported to them. And again, if it doesn't result in hospital admission, according to the FDA, it's not a serious injury and therefore doesn't have to be reported at all. The third criteria, so death is pretty unambiguous. Serious injury gets kind of fuzzy, but at least there's some parameters around it. The third criteria is unreasonable risk of either death or serious injury. And if we can't really clearly identify serious injury, I have no idea what the expectation is for unreasonable risk of death or serious injury. In my opinion, if something goes flying across the room, if there is a loose projectile event, that is an unreasonable risk of death or serious injury. Doesn't matter that it didn't hit anybody, in my opinion, that's an unreasonable risk. Oh, the world is falling behind you. So the FDA doesn't see it that way. The FDA, and I understand, they're trying to manage a whole sea of different, devices and drugs and that sort of thing, and they're looking for lowest common denominator means of describing the risks and the harms and the reporting requirements. If I were king of the world, I would have MR specific adverse event reporting requirements that dealt specifically with the risks that we have in MR. Unfortunately, nobody's given me that position just yet. So in the meantime, we kind of have to deal with what the FDA lays out for me and for everybody. My recommendation is if you got scared because of what happened, the thing went flying and you're like, oh, thank God there wasn't a patient there or a staff member there. Your emotional reaction essentially says there was an unreasonable risk of death or serious injury. If you were scared by that, that's probably, should be a reportable event. You should tell that to your manufacturer, and preferably you should report it directly to the FDA. I was, for something else, I was actually looking yesterday at a bunch of adverse event reports that got submitted through a manufacturer to the FDA. And the interesting thing is when they go through the manufacturer, they all get kind of whitewashed with the explanation that, well, our manual says not to do this thing that the folks at the site did. So clearly it's not our fault, it's on the site. So when it's reported from the manufacturer, there is a very clear impetus to report it in such a way that makes it clear that the manufacturer had nothing to do with this. And it kind of shifts the responsibility or the blame to the site. Sometimes that's deserved, but sometimes it's not, I think.
Mm-hmm. Interesting. So one last question before we wrap up. What piece of advice in regards to MRI safety would you give new MRI technologists entering the field?
Man, that's a big question. Man, stay intellectually curious. MR, the technology, the clinical application of MR as a scanning tool, our patient cohorts, the degree to which we're intervening with patient well-being during concurrent with the MR study. All of those things are changing so dramatically. I mean, just the last 20 years of MR have seen some remarkable technological and clinical and operational changes that have gone on. And what this has meant to techs who, maybe today are closer to the end of their career than the beginning, those techs are having to essentially unlearn a lot of the rule of thumb, or this is always true in all situation kind of, truisms about MRI. 20 years ago, the thought that, we'd be scanning patients who have pacemakers. I mean, 20 years ago, if you insisted that a patient with a pacemaker was going to get scanned, you'd have mass defections on your hands. Techs would just, walk out the door. And there is a lot of that sort of legacy hesitancy to deal with MR conditional, pacing devices today, because we thought it was a death sentence 20 years ago. Technology has changed. Clinical practice has changed. And I think that the demands of technologists who are starting today and are looking at, 20, 30, God willing, 40-year careers in MR, you're going to have to learn so much new stuff and then unlearn so much stuff that, was, true for all time at the time that you were taught it. Staying intellectually curious and flexible and recognizing that as the technology changes, so too do our responses in terms of safety and safe practices. And that will undoubtedly mean if you have a long, successful career in MR, you're going to be asked to do things that you were told we can't possibly do, at some earlier time in your career. And while that might have been true at that earlier time, things might have changed enough that it might not be as true today as it was back then. So be open to the change and seek out the information that will help you to effectively manage that change as it occurs, because I don't see it slowing down anytime soon.
I agree. Good stuff. I'd like to thank our guest, Toby Gilk, for joining us today for Friday on our 2022 MRI Safety Week. I'm Alan Heffron, MRI Safety Trainer and MRI Technologist.
Thank you, Alan.
You're most welcome. And we will see you soon on another webinar, podcast, or other programming that Metrasens produces. Thanks so much.
Thank you.